So we have discussed factors influencing appropriate selection of the antimicrobials in last class. So today we shall continue with the chapter, and we shall start with when we need to use combined use of antimicrobials and what are their advantage and disadvantage. So usually treatment with a single antimicrobial agent is adequate for majority of the infections. However, two or more antimicrobial agents may be required in some situations. One of the advantages is to achieve synergism. That means a synergistic drug sensitizes the organisms to the action of the other member of the pair. More rapid laser action is exhibited by combination of the beta-lactam antimicrobial with aminoglycoside. Beta-lactam, they disturb the cell wall, whereas aminoglycoside disturb the cell membrane. So together, if they are combined, they have a synergistic effect. And it has been seen that decrease in the MIC of one antimicrobial in the presence of another, or the MIC of the both may be lowered. So there can be decrease in the MIC of one antimicrobial, or there can be decrease of the MIC of both antimicrobial. That means they can be given in lower dose if combined. If the MIC of each antimicrobial is reduced to 25% or less, the pair is considered synergistic. And if it is reduced by 25 to 50%, then it is considered additive. And more than 50% of reduction indicates antagonism. So we desire so that combination should lower one each MIC by 25% or less. Two bacteriostatic agents are often additive, rarely synergistic. Combination of tetracycline, chloramphenicol, erythromycin, etc. A sulfonamide used with trimethoprim is a special case where suppurative effect is obtained because of sequential block in the folate metabolism. When you shall read sulfonamide, you shall find that sulfonamide with trimethoprim, they block sequential pathway of a metabolic pathway of folic acid synthesis. So that exerts suppurative effect. So combination use of beta-lactam inhibitor also, like clavulanic acid or sulbactam with amoxicillin or ampicillin for beta-lactamase producing H. influenzae and Haemophilus influenzae and Neisseria gonorrhoeae is a common practice. So what is the beta-lactamase inhibitor? It degrades the beta-lactamase enzyme. It is mainly expressed by the gram-negative bacteria. They degrade the beta-lactam antibiotics. So beta-lactam antibiotics like penicillin, cephalosporin, they are mainly active on the gram-positive bacteria because they cannot penetrate the gram-negative outer membrane protein, and also they are degraded by the beta-lactamase produced by the gram-negative bacteria. So beta-lactamase inhibitor is a group of antibiotic which is used along with this penicillin or cephalosporin so that their activity against the gram-negative bacteria is still present. So to have greater activity against the gram-negative, beta-lactam antibiotic is commonly combined with the beta-lactamase inhibitor. So these are the example of synergistic effect. And two bactericidal drugs are frequently additive and sometimes synergistic if the organism is sensitive to both, like penicillin plus gentamicin. So penicillin is beta-lactam and gentamicin is aminoglycoside. So as one is damaging the cell wall, one is damaging the cell membrane, so they are frequently synergistic. And penicillin, by acting on the cell wall, may enhance the penetration of the aminoglycoside into the bacterium. Rifampicin and adenosine is another example. This combination is commonly used in tuberculosis. But remember, combination of bactericidal drug and bacteriostatic drug is problematic. If the organism is highly sensitive to the cidal drug, response to the combination is equal to the static drug given alone. What does that mean? That is apparent antagonism. That means bacteriostatic drug, they decrease the proliferation, and when they can decrease the proliferation of the bacteria, if the bacteria is highly bactericidal drugs, when they are mainly active, bactericidal drugs are active mainly when bacteria population are rapidly proliferating. That means if their growth is inhibited, cidal drug cannot exert their activity. So that is the common situation happens if cidal drug is combined with the static drug. So static drug will decrease the growth rate and cidal drug will be less active on that static situation. So there will be relative antagonism. So cidal drug is not, we cannot get the actual action of the cidal drug if it is combined with the static drug. So because cidal drug acts primarily on the rapidly multiplying bacteria, static drug retards the multiplication. And that's why penicillin is not combined with the cidal drug, a static drug like tetracycline, chloramphenicol, especially in the pneumococcal infection. So remember this, aminoglycoside can be combined with the beta-lactam for the synergistic effect, but tetracycline chloramphenicol, they are bacteriostatic, cannot be combined with the beta-lactam, which is a bactericidal drug, because we cannot get the cidal effect adequately. So cidal drug and static drug should be avoided as far as possible. If the organism has low sensitivity to cidal drug, synergism may be seen like streptomycin but tetracycline in brucellosis, rifampicin and dapsone in leprosy. So if the organism has low sensitivity to cidal drug, there can be synergism. So this situation can be reversed in two situations. If the organism is highly sensitive to cidal drug, response to the combination is equal to the static drug given alone. So because cidal drug cannot be active on the static population, and if the organism has low sensitivity to cidal drug, then synergism may be seen. So here static drug, the bacteria is mainly active on sensitive to static drug. That's why static drug need to be given, but cidal drug here will increase their effect of the static drug, because cidal drug will decrease the population of the bacterial population, and static drug will act predominantly only on the less number of the population, and there will be synergistic effect. So remember this: if bacteria is predominantly sensitive to the cidal drug, then cidal and static drug should not be combined. But if bacteria is less sensitive to cidal drug, then cidal drug and static drug can have synergistic effect. Number 2, to reduce the severity or incidence of the adverse effect. This is possible only if the combination is synergistic, so that doses can be reduced. So synergism means you can give it in lower dose, then adverse effect of each drug can be minimized. This is needed for the antimicrobial with low safety margin, like streptomycin can be combined with the penicillin for the subaqueous bacterial endocarditis. Amphotericin B and flucytosine, both are nephrotoxic drug, can be combined with in the cryptococcal meningitis. To prevent emergence of the resistance mutation, there is an important aspect of advantage of using combination antimicrobial. It confers resistance to one antimicrobial is independent of that conferring resistance to another. So suppose in one population of bacteria, 1 in 10 to the power 5 bacteria is resistant, and if we give monotherapy in that bacteria, then chance of developing resistance will be relatively high. But if we can combine with another antimicrobial whose resistance is 1 in 10 to the power 6, then if we combine both, then chance of development of resistance will be 1 in 10 to the power 11. So it confers resistance to one antimicrobial is independent of the conferring resistance to another, and it is widely employed in tuberculosis, leprosy, and also HIV. So here combination therapy is given so that a single bacteria has less chance of developing resistance to multiple drugs. To broaden the spectrum of the antimicrobial action, treatment of mixed infections when they are gram-positive, gram-negative, aerobic, anaerobic, many kinds of bacteria are responsible for causing the infection, like in presence of bronchiectasis, pneumonitis, brain abscess, diabetic foot, gynecological and genitourinary infection. Then combination therapy is needed so that we can target both gram-positive as well as gram-negative, aerobic, anaerobic. So remember, gram-positive action is mainly seen by the beta-lactam groups. Gram-negative inhibition is mainly done by the aminoglycoside group. Anaerobic inhibition may be mostly done by the metronidazole. So if we combine this aminoglycoside, metronidazole as well as some beta-lactam drugs, then most of the infections can be controlled. Often aerobic and anaerobic organisms sensitive to different drugs are involved. Initial treatment of severe infection, which I have discussed, that then probably we need empirical therapy because the organism is not known. So bacterial diagnosis is not known. Drugs covering gram-positive, gram-negative as well as anaerobes can be given, like penicillin plus streptomycin, or cephalosporin plus aminoglycoside plus metronidazole, or clindamycin to cover the anaerobe. So when either there can be mixed infections, so an organism is known but multiple organisms have been isolated, like in presence of bronchiectasis, pneumonitis, peritonitis, diabetic foot, and also in patient in septic condition but organism is not yet known, report is not yet available, but patient is in critical condition, then also we need to give combination therapy to control or to target multiple or group of bacteria. So these are the advantages of the antimicrobial combination, But what are the disadvantages? This is not a rational outlook. We cannot provide we cannot give combination to all, because rational therapy means you have to target give one. If you want to target one microorganism, then antimicrobial should be given to target that particular microorganisms. Then chance of production of resistance as well as adverse effect is less. And number 2 is increased incidence of variety of adverse effects like vancomycin plus tobramycin and gentamicin plus cefalozin produce accelerated kidney failure. There is increased chance of superinfection. Superinfection is infection which is caused due to suppression of the common general bacterial flora which is present in our body, mainly in the gut or in the gum. In inadequate dose of non-synergistic drugs are used, there is chance of development of resistance. So if we give combination, we must be sure that dose must be adequate. So inadequate dose actually leads to development of resistance. And also, if we give combination therapy to all, there will be increased cost of therapy. So there will be increased adverse effect, increased chance of resistance if it is dosed inappropriately, and there is increased cost of therapy, increased cost of chance of superinfection. So there are disadvantage of the combination therapy, but advantage is that we can have synergistic action sometimes. We can give it in empirical therapy, we can give it in mixed infection, and we can have sometimes decreased adverse effect because if synergism produces decrease in the dose. And also it can, in chronic conditions, when like in tuberculosis, leprosy, when drug needs to be given for a long time, then it prevents development of the resistance. Next, so what are the common problems of use of antimicrobial agents? Most common is drug resistance. Nowadays, most of the antimicrobials is not effective against many bacteria because of the resistance. So unresponsiveness of a microorganism to an antimicrobial agent is drug resistance. It can be natural or it can be acquired. So naturally, some microbes have always been resistant to certain antimicrobial agents. They lack the metabolic process or the target site which is affected by the particular drug. Like gram-negative bacilli are normally unaffected by the penicillin G, or Mycobacterium tuberculosis is insensitive to tetracycline. So this is natural resistance. So they lack the target site which is affected by the particular drug. And acquired resistance is development of resistance. So natural resistance, we know that we cannot use tetracycline against tuberculosis, we cannot use penicillin against the gram-negative bacilli. That is not a problem, but the problem is acquired resistance. Here, bacteria was initially sensitive to that microorganism, but after development of resistance, over a certain period, there is development of resistance due to an antimicrobial agents over a period of time, which was sensitive before. So previously it was sensitive, but bacteria has developed some way to bypass its action, and thus that antimicrobial is now not active on that microorganisms. So this can happen with any microbe, and it is a major clinical problem. Resistance may be developed by the mutation or gene transfer. You have read it in class 12. What are the steps of the mutation or the gene transfer? So mutation can be stable and heritable genetic change. It occurs spontaneously and randomly among microorganisms. It can be single step or multi-step. So single step is single gene mutation, may offer high degree of resistance. It emerges rapidly, like Enterococcus streptomycin, E. coli, and Staphylococcus to rifampicin. So this is a single step mutation, and multi-step mutation is a number of gene modifications are involved, and sensitivity usually decreases gradually in a stepwise manner. And gene transfer from one organism to another can occur by the conjugation, transduction, and transformation. So what is conjugation? It is sexual contact through the formation of a sex pilus that is common among the gram-negative bacilli of the same or another species. It can be chromosomal or plasmid mediated, and this gene carrying the resistance or R factor is transferred only if another resistance transfer factor is also present. So R factor need to be present, also resistance transfer factor, that is RTS, need to be present also, and conjugation frequently occurs in the colon. Transduction, it is the transfer of gene carrying a resistance through the agency of a bacteriophage. The R factor is taken up by the phage and delivered. The R factor means resistance factor is taken up by the phage and delivered to the another bacterium which it infects. And many Staph aureus strains have acquired resistance by transduction. Transformation, a resistant bacterium may release the resistance carrying DNA into the medium. may be imbibed by other sensitive organisms and becoming unresponsive to the drug. And there is example is pneumococcal resistance to penicillin due to altered penicillin binding protein. So these are the methods by which drug organism can develop drug resistance, either can be mutation or by gene transfer through conjugation, transduction, transformation. Now, so far these are my questions. Number 1, penicillin can be combined with gentamicin, that is an aminoglycoside. True or false? If false, you have to answer this with reason. True or false? Why? Number 1, penicillin can be combined with gentamicin, that is an aminoglycoside. True or false? With reason. Number 2, penicillin can be combined with tetracycline. True or false? With reason. Penicillin can be combined with tetracycline. True or false? With reason. Number 3, what are the common methods of gene transfer? What are the common methods of gene transfer for mutation? Number 4, give example of one drug having natural resistance. Give example of one drug of which is naturally resistant to an microorganisms. Give one example of a antimicrobial which is naturally resistant to. Give an example of a drug which is naturally not effective against a microorganism. And number 5, what is discuss 2 advantage of antimicrobial combination. Number 5, tell 2 advantage of the antimicrobial combination. Next, so variety of resistance. What can be? There are multiple variety of resistance. One can be called drug tolerance. There is loss of affinity to the target molecule of the microorganism to a particular antimicrobial agent. So the target site is damaged. Certain penicillin resistant pneumococcal strains have altered penicillin binding proteins. Trimethoprim resistance results from plasmid mediated synthesis of a dihydrofolate reductase that has low affinity for trimethoprim. So trimethoprim is a dihydrofolate reductase inhibitor. So resistance will cause a plasmid mediated synthesis of a defective dihydrofolate reductase, and it has low affinity of trimethoprim. So trimethoprim cannot block it properly. And also for penicillin binding protein, if it is altered, then penicillin cannot bind properly in a pneumococci. So this is the example of drug tolerant. Staph aureus and E. coli develop a RNA polymerase that does not bind rifampicin. Drug destroying, that is more damaging. So resistant microbe elaborates an enzyme which inactivates the drug. So beta-lactamase, I have mentioned the beta-lactamase produced by many gram-negative bacteria like Haemophilus, gonococci, which inactivate the penicillin. That's why the penicillin is not effective against the gram-negative bacteria. So beta-lactamase located in the periplasmic situation, periplasmic location, so that the drug is inactivated soon after entry. So it is inactivated by the gram-negative bacteria soon after their entry. It is the drug destroying. So drug tolerant means alteration of the target protein. Drug destroying means destruction of the antimicrobial by production of an enzyme by the bacteria. Also, chloramphenicol acetyl transferase is acquired by the resistant E. coli, H. influenzae, and Salmonella typhi. Some of the aminoglycoside resistant coliforms have been found to produce enzyme which either adenylate or acetylate or phosphorylate specific aminoglycoside antibiotics. So, apart from beta-lactamase, chloramphenicol acetyl transferase is another example of drug destroying enzyme. Also, aminoglycoside can be destroyed by adenylation, acetylation, or phosphorylation. Drug impermeable. Many hydrophilic antibiotics gain access into the bacterial cell through specific channels formed by proteins called porins or need specific transport mechanisms. And this, if they are damaged by resistant strains, then they cannot achieve, the drug cannot achieve higher concentration inside that bacteria. The concentration of some aminoglycoside and tetracycline in the resistant gram-negative bacterial strains is reduced. So if there is problem in the purine channel or specific transport mechanisms, then antibiotic cannot get access into the bacterial cell. So that is called drug impermeable. So low degree of penicillin resistant gonococci are less permeable to penicillin G. Chloroquine resistant Plasmodium falciparum also accommodates less chloroquine. Next is increased efflux. So bacteria may also acquire plasmid-directed inducible energy-dependent efflux proteins in their cell membrane, which pump out tetracycline. So active efflux-based resistance has been detected for erythromycin and fluoroquinolone. So this is the example by which the drug resistance occurs. So one is alteration of the target protein. Example is alteration of the penicillin binding protein by the pneumococci. Number two, drug destroying by elevation of some enzyme by beta lactamase enzyme products produced by the gram negatives, chloramphenicol transferase, and also aminoglycoside adenylation, acetylation, phosphorylation. Number three, alteration of the purine channels or transport protein, which will cause, if it is altered, then the drug cannot access into the bacteria properly. And number four, excess production of the efflux protein like P-glycoprotein, which will cause exit of the drug from the bacteria. Also there is one example, antibiotic dependence, that is very rare, that is vancomycin dependent enterococci. So here what happens, enterococci will use vancomycin as their nutrition source. So that is called antibiotic dependence. That is very rare, but that is a unique variety of the drug resistance. So you should remember, number one is alteration of the target protein, number two, elaboration of some drug destroying enzyme, number three, alteration in the purine channels, number four, increased efflux, and rarely there can be antibiotic dependence. So how can I prevent drug resistance? No indiscriminate and inadequate use should be the motto, and inadequate or unduly prolonged course of the antimicrobial should be avoided. So antimicrobial, if it is used, must be used for the certain duration, must be used judiciously, or also must not be used for prolonged time, and no indiscriminate use. What are the indiscriminate use of antimicrobial? So commonly there are few conditions where antimicrobial need to be given, is falsely given, like viral illness like sore throat, rhinitis, etc., and measles, mumps, respiratory infections. They are often, antimicrobials are wrongly prescribed, so we have to avoid that. Also, there can be chance of prolongation of the antimicrobial therapy in some conditions where origin of fever is not known, it is called fever of unknown origin. Inadequate dosage and duration of treatment is also problematic, that will cause development of resistance. And we should prefer rapidly acting and selective antimicrobial whenever possible. So initially we can rely on empirical therapy when culture report is not obtained, but when we have known the organism, and unless it is a chronic therapy like tuberculosis, we have to rely on the narrow spectrum drug, and often monotherapy or maximum double two drug combination is often sufficient. But if it is tuberculosis, leprosy like therapy which need to be treated for months or years, then we may take help of the 3 to 4 drugs combination to prevent the development of resistance. So when the microorganism is known, we should target it properly with narrow spectrum drugs. Number 3, use of combination antimicrobial when prolonged therapy is undertaken like tuberculosis, leprosy. Number 4, infection by organisms notorious for developing resistance. So there are some microorganisms which is resistant to many drugs, for like Staphylococcus aureus, E. coli, macron tuberculosis, protease, etc. They must be treated intensively. So they must be treated with some special drugs, maybe with some combination, and maybe for a certain period of time. So remember this: no infection, no indiscriminate inadequate use. Prefer rapidly acting and selective use. Use combination of antimicrobial whenever prolonged therapy is undertaken, and infection by organisms notorious for developing resistance should be treated intensively. Next common complication of antimicrobial therapy is superinfection. So superinfection is the appearance of a new infection as a result of antimicrobial therapy. So here prolonged therapy is actually will cause prolonged suppression of the normal body flora, which is causing the superinfection. So it is commonly associated with the use of broader extended spectrum antibiotics such as tetracycline, chloramphenicol, ampicillin, some cephalosporin, and more common when host defense is compromised. So when host defense is compromised and if antibiotic is given for long term, then mainly broad spectrum drugs, then the common flora which is present in our gut or gum or genitourinary tract, they are suppressed and that can cause superinfection. So sites involved in superinfection are those normally have the common subs like oropharynx, intestinal, respiratory, and genitourinary tracts, occasionally skin. So which are the common organisms which are frequently involved in this infection? Candida albicans, which can cause candidal esophagitis or oropharyngeal candidiasis. Clostridium difficile, it can cause a particular colitis which is called pseudomembranous colitis. Candida albicans cause esophageal candidiasis or oropharyngeal candidiasis. Clostridium difficile can cause pseudomembranous colitis, and Pseudomonas can cause pneumonia. So these are the common organisms which are responsible for the development of the superinfection, and drugs commonly responsible are tetracycline, chloramphenicol, cephalosporin, and also other extended spectrum drugs. So conditions predisposing to superinfection. So what can predispose a person to develop superinfection? One is if its immunity is also already suppressed, either due to corticosteroid therapy or in presence of leukemia or other malignancy, especially when treated with the anti-cancer drug. So anti-cancer drug will reduce your immunity, corticosteroid will reduce your immunity. So in those immunosuppressed states, there is more development of the superinfection. In HIV patient, it granulocytosis, diabetes, and disseminated lupus erythematosus. So these are the immunocompromised states when there is chance of superinfection. Systemic toxicity: aminoglycosides can cause AIDS, renal nerve damage, and kidney toxicity. Tetracycline can cause liver and kidney damage. Chloramphenicol can cause bone marrow suppression. It can be dose related, it can be idiosyncratic. Polymyxin B can cause neurological or renal toxicity. Vancomycin can cause hearing loss, kidney damage. Camptothecin B can cause kidney damage, bone marrow suppression. So these are the adverse effects of specific antimicrobials. We have to read it in detail when we discuss the specific antibiotics. So remember the superinfection, this is very common. The asked question in the remember the methods of development of the resistance and what are the types of drug resistance. Conditions predisposing to superinfection, these are the commonly asked questions. Next is hypersensitivity reaction. So these are unpredictable and unrelated to dose. The whole range of reactions can run from the rashes to anaphylactic shock. And the more commonly involved antimicrobials are penicillin, cephalosporin, sulfonamide, and fluoroquinolones. Some of the B complex group antivitamins and vitamin K are synthesized by the intestinal flora, and if it is suppressed due to prolonged use of the broad spectrum drug, then this vitamin deficiency can happen. So there can be development of the vitamin K deficiency and vitamin B12 deficiency mainly. So neomycin can cause morphological abnormalities in the intestinal mucosa. Steatorrhea, malabsorption syndrome can occur. So neomycin is an anti-aminoglycoside. It can cause malabsorption syndrome due to and as it called malabsorption syndrome, it can cause decreased absorption of the water-soluble vitamins. Masking of an infection can happen. A short course of antimicrobial therapy may be sufficient to treat one infection, but only briefly suppress another, which can be present concurrently. So the other infection will be masked initially, and that can manifest later in a severe form. Example: syphilis is masked by use of a single dose of penicillin, which is sufficient to cure gonorrhea. So syphilis and gonorrhea often that can be present concomitantly in a single patient, and a single dose of penicillin is sufficient to treat gonorrhea but not sufficient to treat syphilis. So initially symptoms can be resolved, but syphilis can reappear later. So tuberculosis also can be masked by a short course of streptomycin given for trivial respiratory infection. Streptomycin, apart from streptomycin, remember we should avoid indiscriminate use of the fluoroquinolone like levofloxacin, moxifloxacin, and also macrolide like clarithromycin, because tuberculosis symptoms can be masked by them. So and there can be an important drugs in the second line drug for the treatment of the tuberculosis. So if it is used indiscriminately, then we may lose an resource of treating tuberculosis. So, tuberculosis, for treating the tuberculosis, we have to keep the sensitivity of the oxytocin, levofloxacin as well as clarithromycin to the upper level, so that indiscriminate use will not cause drug resistance. So types and goals of antimicrobial therapy. So these are the problems of the antimicrobial therapy. Indiscriminate use can cause nutritional deficiency, masking of the infection, hypersensitivity reaction. So far for my next few questions, number 6. So we have discussed 5 questions. So number 6 question. Discuss the 4 major pathways by which a organism develop drug resistance. Discuss the 4 major pathways by which an organism develop drug resistance. That means you have to mention the pathway, whether there is alteration of the target site, etc. Those 4 mechanisms we have to mention. What are they responsible for the drug resistance? Number 6. Commonly, discuss 2 conditions. Discuss name 2 antibiotics which can commonly cause superinfection. Name 2 organisms which are commonly involved in the superinfection. Number 6. Number 8. Which drugs commonly cause hypersensitivity reactions? Which drug commonly cause hypersensitivity reaction? Okay, let's continue. So types and goals of antimicrobial therapy. So it can be starting from prophylaxis to the suppressive. So when there is no infection but there is a risk factor, we can give prophylaxis. After infection, when organism is not known yet, we can give empirical preemptive therapy. When symptom is also not absent, it is not commonly given because patients commonly come after development of the symptoms. So after symptoms, if his organism is not yet isolated, then we can start with empiric therapy. After pathogen isolation, then we have to give definitive therapy, that is narrow spectrum. So for prophylaxis, when there is no infection but patient has risk factor for development of infection. When infection is present but there is no symptom, we can give preemptive therapy. After symptom development, we can give empiric therapy. After pathogen isolation, we have to give definitive therapy. And after resolution, sometimes to prevent relapse, for example in malaria, we have to give some suppressive therapy to prevent development of the reinfection. So what are the examples of the prophylactic therapy? There are multiple examples, but remember the most prophylaxis against specific organisms. Rheumatic fever, so group A streptococcus is responsible, and long-acting penicillin G is the drug of choice for the preventing recurrence. Actually, benzathine penicillin is used, and I have mentioned the dose during the discussion of the acute rheumatic fever. So, if a patient develops rheumatic fever, for prevention of the recurrence, benzathine penicillin 2.4 million unit is given every 3 weeks for 5 years or up to 21 years of age, whichever one is longer. So, if patient develops rheumatic fever at the age of 16 years, at the age of 15 years, then we have to continue it up to 21 years. But if it develops rheumatic fever at age of 18 years, then we have to continue it for the 23 years. That is the 5 years. So 5 years or up to 21 years, whichever one is longer. Sometimes we have to give prophylaxis against tuberculosis, like children or HIV positive susceptible contacts open case. Isoniazid or alone or maybe with rifampicin is recommended. HIV infection, healthcare workers exposed to blood by needle stick injury, often we have to give drug that is also called post-exposure prophylaxis with 0-vodin, lamivudine, indinafil. So offspring of HIV positive women can be protected by 0-vodin given to pregnant mother and then to newborn for 6 weeks. But now 0-vodin is not commonly used. We have to use nevirapine. So these are the examples of the prophylaxis drug. Malaria, for travelers to endemic areas with high transmission of rate, chloroquine is used. So if a European wants to visit India, he or she needs to take chloroquine for prophylactic purpose to prevent malaria. So remember the rheumatic fever, remember the tuberculosis, remember the post-exposure prophylaxis. We shall discuss it again. Prevention of infection in high-risk situations like dental extraction, tonsillectomy, chronic bronchitis, then often antibiotics are given before development of the infection. Prophylaxis of surgical site infection. So before surgery, a single dose of antibiotic is often given to reduce the incidence of the surgical site infection, and those should be minimal, because we don't want suppression of the normal microbial flora. So these are the drugs which can be used for surgical prophylaxis. Commonly we use cephalexin 2 gram or cefadroxil 2 gram. Parenteral, it is for oral, or we can give cefazolin 1 gram IV. So either we can give cephalexin orally, or we can give cefazolin or ampicillin IV for surgical site infection prophylaxis. So my next few questions. Number 9, discuss two situations where we have to give antibiotic prophylaxis. Number 10, which drug is used in surgical site prophylaxis parenterally. Number 10, which drug is used surgical site prophylaxis parenterally. So number 9 question is discuss two conditions where we need to give antibiotic prophylaxis. Number 10, surgical site prophylaxis, name the parenteral drug. Okay, so this is the antimicrobial. Remember the common methods of development of the resistance. What are the problems of the antimicrobials? Remember the superinfection. Or regarding the superinfection, the pseudomembranous colitis, which is caused due to Clostridium difficile, drug of choice is metronidazole, and for candida infection, drug of choice is fluconazole. So this is the mission: avoid antibiotic abuse, become aware about antibiotic misuse, and it is the chief weapon to fight bacterial infection. And we have conquered many diseases with antibiotics, but if it is resistant, then this weapon will be useless. So self-medication is harmful. Don't use antibiotic given to you for others. Always complete the course as advised. And safe use of antibiotics, it is the responsibility of all of us. And National Antibiotic Day is observed in September 28, and Antibiotic Awareness Week is observed from September 28 to October 5. Thank you.